Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to discuss classification, pathophysiology, and diagnosis of acute coronary syndrome. Acute coronary syndrome, ACS, is the serious acute presentation of ischemic heart disease, which is caused by coronary artery disease, compromising the blood flow and oxygenation of myocardial cells, leading to acute myocardial dysfunction, acute myocardial ischemia, or infarction. ACS can be classified as unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. If the total occlusion of a coronary artery occurs, it could lead to NSTEMI. On the other hand, NSTEMI results from partial non-occlusive coronary artery. This classification is important because current treatment strategies of ACS depend on the initial ECG changes. For example, STEMI would benefit from immediate reperfusion therapy. However, fibrinolytic agents should not be used in NSTEMI. Unstable angina is considered when patients present with symptoms of ischemic type chest pain, which could frequently occur at rest or on minimal exertion, which is more severe and prolonged than the usual angina, and which is also more difficult to control with drugs. It usually results from an imbalance between myocardial oxygen supply and demand, with limitation of myocardial oxygen supply and background of coronary artery stenosis. Ischemic ECG changes, for instance, ST segment changes or new T-wave inversion may be present without any rise in troponins. Patients with acute myocardial infarction could present with symptoms of unstable angina with ischemic ECG changes as aforementioned. The difference is that there would be elevated serum troponin level, which means that myocardial injury is present due to myocardial ischemia. Nevertheless, the rise in troponin levels would not indicate the underlying pathophysiological mechanisms. Now, let's talk about pathophysiology of myocardial infarction. Myocardial infarction is mainly caused by coronary artery disease and usually precipitated by rupture or erosion of atherosclerotic plaques in coronary arteries. Atherosclerotic plaques are often vulnerable and they tend to have a thin fibrous cap over a central core of foam cells, lipids, and necrotic debris. The exact cause of plaque rupture is generally unknown. The triggers could be infection or inflammatory processes with activation of metalloproteinase enzymes, which can break down collagen in the fibrous cap and inhibit synthesis of new collagen, and acute hemodynamic stress, which can be associated with increased sympathetic tone. When the plaques rupture, they will be exposed to circulating blood, causing adhesion of platelets. Platelets cluster to form white thrombus, and this alone could rarely occlude the vessel completely. Exposed lipid, fibrin, and aggregated platelets will activate coagulation cascade, forming thrombin, and eventually fibrin clots. Red cells flow through these clots will be trapped and form red thrombus complex surrounding the white thrombus. Ultimately, this whole mechanism will result in coronary blood flow obstruction and myocardial cell death due to prolonged ischemia. Subendocardium is the layer at the highest risk since it is the farthest away from the coronary artery supply, and the first microscopic changes can be seen within 10 to 15 minutes after the onset of myocardial ischemia. It can take hours before myocyte necrosis progresses from subendocardia to the subepicardium. The process of transmural myocardial infarction may be hindered by increased collateral coronary flow, reduced factors of myocardial oxygen consumption, and timely reperfusion therapy if appropriate. After the pathophysiology, I would like to discuss the types of myocardial infarction. Basically, myocardial infarction is the death of cardiac myocardial cells due to the consequence of myocardial ischemia. We call it type 1 MI if the myocardial ischemia is caused by atherosclerotic plaque disruption with thrombosis, as I mentioned earlier. Type 2 MI occurs when myocardium is injured by ischemia due to coronary blood supply and demand mismatch. Myocardial perfusion can be diminished by coronary artery narrowing, which could be due to arterial spasm, progressive atherosclerosis, or restenosis after PCI. Patients with chronic atherosclerotic narrowing are susceptible to demand ischemia when there is increased myocardial oxygen demand during fever, tachycardia, or severe hypertension, and when there is reduced oxygen delivery during respiratory failure, hypotension, or severe anemia. Moreover, myocardial injury could be due to cardiac pathologies, for example, heart failure, cardiomyopathies including Takotsubo, myocarditis, cardiac procedures such as coronary revascularization and catheter ablation, chest compression during CPR, and defib shocks. Also, systemic conditions, for instance, sepsis, CKD, stroke, amyloidosis, chemotherapy, and critical illness could lead to myocardial damage. Patients with myocardial infarction, not more than 50% of angiographic coronary artery obstruction, are now grouped in the term myocardial infarction with non-obstructive coronary arteries, MINOCA. Differentiating between type 1 and type 2 MI is very important in critical care setting during severe acute illness or post-operative period because increased troponin levels can be seen in both types. However, dual antiplatelet therapy is normally indicated in type 1 MI only. It is crucial to consider the use of echocardiography to identify the regional wall motion abnormality. Diagnosis of ACS is quite challenging because there are lots of cardiac and non-cardiac causes and comorbidities that can present as ACS. Therefore, when we review patients with suspected ACS, we need to assess the clinical presentation, do proper history taking and examination of the cardiovascular system, standard 12-lead ECG, and serum troponin level. The diagnosis of myocardial infarction, especially type 1 MI, can be made when the rise of cardiac biomarker values like cardiac troponin is above the 99th percentile upper reference limit and when there is at least one of the features such as symptoms of ischemic chest pain, ischemic ECG changes, intracoronary thrombus during coronary angiography, or new regional wall motion abnormality in echocardiogram. Let's elaborate the diagnostic features. In this part 1 video, I will talk about the clinical presentation. In part 2 video, I will continue to discuss the investigation techniques to diagnose ACS together with the management plan. The typical ischemic chest pain is retrosternum. Pressure or squeezing in character may radiate down the ulnar aspect of both arms up to throat and jaw or to the interscapular area or epigastrium. It is usually severe and constant with duration of more than 20 minutes with or without aggravating factors like physical exertion or stress and relieving factors like rest or GTN spray. Autonomic symptoms such as sweating, nausea, pallor, and agitation can often be associated with chest pain. Patients with myocardial ischemia can also present with severe symptoms such as syncope, palpitations, and dyspnea. In extreme cases, sudden death can occur with severe myocardial infarction. Please bear in mind that the clinical presentation can often be atypical or even silent in the intensive care setting, especially if the patients are elderly, diabetic, or alcoholic. Hence, we need to be vigilant to do ECG and check serum troponin level in patients with high cardiovascular risk factors. Sometimes, patients could have missed episodes of MI and present to us with the sequelae rather than the clinical features, which I just mentioned. One of the common presentations is hypertension with pulmonary edema due to cardiogenic shock, which usually results from extensive loss of ventricular contractile function because ischemic myocardial necrosis results in thinning, softening, later fibrosis, and remodeling of the affected myocardium, leading to the change in ventricular compliance. Furthermore, Severe hypotension could be due to profound depression of myocardial contractility following acute catastrophic ventricular free wall rupture of thin necrotic myocardium. Cardiogenic shock in MI patients will create a potentially downward spiral and vicious cycle of reduced cardiac output, low blood pressure, further coronary ischemia, and subsequent reduction in myocardial contractility and cardiac output. This cycle may lead to death if not intervened by adequate treatment. Life-threatening cardiac dysrhythmias are not uncommon as a result of electrical instability due to ischemia, conduction disturbances, and excessive sympathetic stimulation during the course of MI. New murmurs could be heard if there is papillary muscle disruption or rupture, resulting in mitral valve regurgitation, or when ventricular septal defect occurs with extensive interior and inferior wall infarction. In acute clinical setting, it is of paramount importance to differentiate myocardial infarction with other life-threatening conditions. The top 3 differential diagnoses would be aortic dissection if the chest pain is stabbing or tearing in character and radiates to the back with unequal arm blood pressures, pulmonary embolism if there is sharp pleuritic chest pain with hypoxia and clear lung signs, and pericarditis if the chest pain is sharp stabbing in nature, possibly with an auscultatory friction rub. That's it for me in this video. Hope you learned something new. If you did, please share with your friends and colleagues. I'll see you in part 2 video. Take care.